do this every year. We talk about standards because BJC is trying to design our facilities with the best knowledge that we have, learning from the last project we did. And the toolbox doesn't know what the last firm did on a bed tower unless we tell you what it is. So we document what the standards are, and we do that in a very strategic manner. So, strategic manner. My counterpart, Donna Ware, who's at the campus renewal 100% of the time, and I am splitting my time between the campus renewal and PD&C. This is a diagram that Donna created that really talks about how you all, from the beginning of planning and design, and then the contractors go and build those drawings, right? They build what we document. And it all begins with our strategic campus plans. We're planning our facilities from the highest level, doing site analysis about land utilization, to stacking diagrams, to effectively helping the hospitals organize their business case. So we are an extension of always the care delivery model, and we remember that every day, as Marvin and both Greg talked about. So from the strategic campus plans, our conceptual design, we're a very high functioning organization. We do a 10-year look out of our projects called multi-year modeling, and then we do a 2-year capital cycle. So the intellectual property we have about why we're doing a project, it always has to have a pro forma of why are we building it? Why are we building it? So when you get an RFP, you should be asking, why are they building this? What is the business case? Are we adding volume? Are we doing a physician recruitment plan? Are we consolidating services? It's really not just a piece of paper that has a bunch of rooms and departments listed on it. It's bigger than that. So in conceptual design, we really want everyone to have a program, a functional program, and understand what standard rooms are being built in that project. And that's really important to us because what we're really trying to do is get to a point where we can share our staff. So if surgical volumes are down on Thursday afternoon, instead of sending staff home, we could send them to Missouri Baptist. Well, if the ORs aren't laid out the same, we can't do that. If the bed floors aren't laid out the same, we can't do that because they can't go to work in the environment. They're going to spend too much time fetching and looking and being frustrated. So we have standards for a business model reason. So what we don't want is anyone starting with a blank sheet of paper, and we use the intellectual property from the end users in a very specific way, but not just asking them, well, what do you want? That individual, by the time we open it, most of the times don't even work there anymore. So as an organization, we need to decide how we're delivering care. At the campus renewal, we're calling these common rooms because they're common amongst Children's Hospital and an adult hospital. Wow, how iconic is that, right? We're delivering care, we're doing labs and medicine, the exact same, right? The patients are just a different size. So through design development, construction documents, construction and occupancy and closeout, it's really this medical planning and architectural design coming together and working as a team. Like Marvin said, it's a team effort. And as most of you know, I am always challenging and pushing and striving for that excellence and wanting the best out of you so that we get the best project. Greg Ziffel is our corporate architect, and his role is really to be the champion to follow the steps all the way through. So he's your checks and balances. So, innovation. The image that I'm showing is the 3rd generation of our office standards, and it is the BJC at the Commons at the corner of Boyle and Clayton Road, and it's a building we're all very proud of. We worked with the architect and the contractor to take our standards and push the envelope. So ask questions about our standards so that you understand where your innovative ideas can be used. So again, just understanding it from the process of, site, exterior, interiors, evidence-based design and lead. Our team is here to work with you through the whole process, but we really want you to focus on the standards and really learn the standards. We have 26 standard rooms, and after the campus renewal this year, we'll have 8 more. We're adding a bunch of common rooms that are more staff-oriented, locker lounges and those kinds of things. But if you're not familiar with the rooms, or you want a one-on-one with myself or Greg Ziffel, we're all here to make sure that you understand what is the no chat mat. Why is it in the med room? It's a safety mechanism that ultimately affects whether or not the patients have gotten the correct drugs. So how the built environment affects the care delivery model is huge. This is really not about designing a facility for a beautiful photograph and you all walking away, but you all really being a part of the post-occupancy and the learning mechanism that we have available to us in our facilities. ICU rooms, we've worked really hard on those. Our EDs, which we're on a couple generations of that as well. And then we have a lot of standards, flooring, owner directs that are really all about facilities and maintenance. So pushing the envelope on the next manufacturer and vendor that came into your office to sell you a product is good for us to understand, but make sure that you understand our standards and what you're bringing back to us, because what we're more worried about is the FTE and the cost of maintaining those materials than we are just implementing the new flooring product. When I first got here, all we were doing is redoing floors because the subs were cutting their prices and they were cutting out floor prep. Well, as you know, we have a contract with Zickel Flooring. And if you've heard anything about Zickel Flooring, you've heard that their cost is high. But if you write a performance spec that says that you want bead bass floors and you want specific, Ardex floor leveling product, if you take the cheap bid, it's not going to give you that quality. So we're not asking for an inexpensive project. We're looking for a quality project. So make sure that you understand, if it's a renovation project or even a new project, how the flooring standards are effectively implemented in your project. So there's a lot of intellectual property that we have, and the challenge is for you all to catch up with us, because unfortunately we're a high-functioning, very intelligent client, and we're using all of our facilities as a learning lab. So just because on the last project you've learned something, remember, we have 12 hospitals and some 8 million square feet of 9 of occupied space. So literally, we're a very high functioning client. ORs. We have, and typically we'll take the standards and we will create a sheet that says what are the last 4 ORs we built. What ORs do we have on the drawing boards? South County, phase 2. We look at those side by side, and we are judging you all against the next architect that has something else on the drawing boards. And you won't know that just because you're doing a project with us, how we're using that information at all times, looking back at our standards and building data. Did you move a door? Why did you move the door? Did you change and make a recommendation of a light fixture change? We take that information on one project and we put it back into the whole. So if you're ever interested in that dialogue back with us, we have that data and we'll be glad to share it with you. Patient care stations is something we've worked really hard on. One of the hardest things we've done recently at the campus renewal is take offices away from case managers in the pediatric environment. Very tough. Why do we take the doors away from case managers? Case managers are pushing the chart. We don't want them sitting in an office with the door closed. We want them out on the floors understanding where is the physician and where is the family, and making sure that our length of stays are not challenged by somebody sitting at their desk. How many people in this room sit in an open office work environment? Just about everybody, right? Everybody's doing it. And so the day of saying, I can't get my work done, or I can't concentrate, the team environment, work environment is very real, and it affects the patients. Every line you draw on a drawing affects the patients. It really does. We have medical office building standards, and we have garage standards, which HOK and others are building in our new parking garage, so we're pretty excited about that. So that's what we've done in the past, and now I'm going to show you some pictures. Greg Ziffel's going to go through his manual practice. But our standards are line drawings, okay? And you really have to study what it looks like in the built environment. So that's BJC at the Commons. You will see a difference in a workstation that looks like this. And well, why does this workstation have higher panels? Who's sitting on the end? Where are these walls that go all the way to the ceiling? Why are they there? So you have to be able to understand how the kit of parts works together with the program, because you're the one who's having to tell the end users, well, I'm sorry, you get 32 square feet, and your job function is a rover. Your job function is a networker, and you sit in 64 square feet. Oh, you're a director? Okay, well then you get the privacy panel for acoustics in case you have to have a conversation with an employee. But we really need your help to implement these, because if Greg and I are just coming back all the time and challenging your drawings, then we're really upsetting the end users. And it's time. About all the hospitals now have effectively implemented the standards. So at the highest levels, they know what these standards are because Donna and I have presented them. Patient room, this is the Boone patient room. Very beautiful. So, we're asking you to implement our standards, but have a dialogue with us if you want to change something, or if you know something that's changing in the world of healthcare. We want the innovation, but we need the templates to be implemented. So again, this is the patient care stations. Unit clerk, why are there overheads over here? These are the case managers and social workers. And then who sits at a workstation that doesn't have overheads, dedicated versus non-dedicated. We have an employee list for the patient care stations. So it's best if in the programming and planning phase that you take the list of employees, you put them in the little matrix, and out comes, it tells you what kit of parts you use, and then you build it in the workflow. If they have a bunch of residents and it's a training nursing model, even at Missouri Baptist, we used, Steelcase has a sync station, and it's very nice because then a whole bunch of people in the academic environment can come up and work together and look over a computer if they're researching something. And then to the highest levels of our technology spaces and treatment spaces, like our ORs. We have worked very hard on the standards of the ORs and the layout and the workflow and that sort of thing. Our challenge is always the anesthesia column with all the cords. The technology of robots coming into the ORs is affected our standards, which is always good. We're making progress. I show you those so that you understand what what our expectation is to the built environment and what we think is a success when you hand us at the closeout of the project, when you give us the images. Where are we going? It's really important to us to continue to grow in our standards. So in the PMP, which is our project management plan, it's a document that we share with our end users and our leadership at each phase of the project. We have them sign off on the scope of the project so that if there's a scope change, everybody's on board with the scope change. Or if the end users are saying, oh, well, you know what, our case managers, they work differently. You know, we put that door back on that room for us. It gets written in the PMP and it goes to the VP of that department and the organization. So accountability is there, but we need your help to make sure we're communicating and sharing the information. Performance-based design is our ability to use our metrics. So we are in a time of when our reimbursements are tied to our facilities. So if a patient leaves and they get a survey and they say that, wow, it was really noisy and every time they took out the trash, my room wasn't clean, and they ding us, it affects our reimbursements. So by project, I can pull the metrics. I can pull any survey information on a department. I can pull staff data. I can pull injuries. Our highest injury units at BJH have been our cancer floors for falls. And so what we want to do is make sure that those patients have handrails from the beds to the toilet, and that the flooring is safe, that the night lights are in the right place, the call lights are in the right place. So it may seem like an elevation to you, but it's a reality workplace for us. So if you're doing healthcare and you want to get into healthcare, you got to learn the business, and you got to walk in the shoes of both the staff and the patients. So those design metrics that we have for performance-based design are available. You just have to ask for them. So we have a checklist for the standard rooms, and for the performance-based design, like I said, we can pull the HCAP scores on patient safety, acoustics, and cleanliness. So healthcare reform has affected everything that we do. And if you're unfamiliar with these 4 laws that are 100% implemented, let us know, because we'll share it with you. Why are we here today? We're here really to build capacity. And how are we going to do that? So there's some stock slides about our policy that everybody should be very familiar with on our projects. And we've been really focused on the construction and the subs. And what we want to do is really start focusing on the architecture group. About maybe 4 or 5 months ago, Kevin, you and I started to kind of reach out to folks, and we started having these little meetings here at the BLI called Minority Mondays. And it was, Kevin asked me to sit in a conference room, and he would meet people, and then I would meet them. And what I was shocked by is the number of individuals that have architecture degrees living in St. Louis, working in other industries. And it's almost like a lost generation of folks. And so Are any of the parking lot people here? So Sandra wanted to use the word parking lot, because though these individuals, it's a list of people that have architecture degrees, design degrees, that are working at bakeries, working at Ameren, working for the city of St. Louis. And we wanted those folks to have an opportunity with the design firms, if you're hiring an individual, if you have an open position, to look at the parking lot. Their skill sets, you'll have to vet yourself. Kaden and I don't know a whole lot about them. We do have the resumes. But if you are interested and have an opening position and you're interested, I think you can contact Kaven for that. The warehouse is really what we're focused on for the RFPs, okay? And as Greg and I are trying to get our arms around what this is really going to look like, we're using the policy as a guide of how we're going to implement in architecture, how we want you to respond to the RFPs. So there's two forms that I believe the CMs use. The good faith document, which is called Form 1. And this document is just in good faith. They have reached out to these individuals for this scope of work. And it's all relative, right? There isn't any reason why Christner, Tom, could use this form when he receives an RFP that says, well, I went to the warehouse and I looked at Adler 3. Opportunity of you all providing a scope of service on that project, whether it's architecture, whether it was design, whether it's production work, whether it's QA, QC, which Greg would really like, because he'd like to really get out of drawing reviews. You guys keep him very busy. Then there's the second form, which is actually the form that says, well, we have chosen to go ahead and partner on this RFP with this individual company from the warehouse, okay? So Greg and I are working right now to revise the RFP so that it will say in the RFP what our expectation is, and then attach the forms so that you all will respond appropriately on an RFP with that. Does that make sense? So one of the things in the warehouse, I believe, for the architects is that you all have Sandra's team, you all have a one-pager on the firms. Is that correct? So I'm not sure how the toolbox can get a copy of all those one-pagers for each one of the warehouse members that are in here, so that you know who's in the warehouse and what is the skill set. So today is an opportunity for, either the architectural firms to sit at the tables and let the warehouse mingle, or everyone can stand and mingle. But that way you can put a name with a face and a firm and then get to know them, whether or not, you can build a relationship with them to provide some services on your project, teamwork. At the campus renewal, where I'm spending 70% of my time, but unlike Donna, I still have my old job, so I think I'm working 200s, I'm not sure. But at the campus renewal, everyone sits together in the PMO. We're all one big team. It's all integrated. And so I would encourage you, as you develop these relationships and you build an RFP, that you consider working in the same environment or finding a way of being a team, because I think there's nothing like being together, having this kind of time and face time. The structure that Jacobs has brought to the campus renewal, I think, is very collaborative, and it provides everyone an opportunity to work together as a team.